Hello, everyone. It's David from CP Solvers. Today we have a VMR, a teaching points recap VMR with Francisco, Tansu, and Ximena, who prepared some great cases from last month. And well, we hope you enjoy it, and um, you can share your comments in the chat. We'll post some questions also, and in the end, after each case, we can try to make some comments or some recaps. If you want to unmute briefly, because they are like between 10 and 15 minutes each case. But if you want to share some thoughts, it will be amazing. Okay. So I'm just passing the mic to Francisco to tell us the first case.
Hey everyone, it's a pleasure to be here. So let me share my screen. Okay, so sorry for that. All right, so can you see the screen now? Perfect. Okay, a little spoil there. Okay, so this is my first presentation. I'm on the teaching points recap. I'm very excited to be presenting a case by Mark. As you know, all Mark's cases are amazing, and it was discussed on a Friday on an RLR. So yeah, full of learning. Embark on this journey with me, and I like to call this presentation "When Life Gives You Melons." You just have to make sure you eat them. Okay, so we start off with a patient that has 37 years old. She's a female and started with the chief complaint is progressive dyspnea. Let me just put this here. And so 2.5 months ago, she presented with lower extremity bruising and swelling. Then she started with dyspnea on exertion and some iron deficiency anemia. And 1.5 weeks ago, she presents again with menorrhagia and refractory iron deficiency anemia. All the studies along the way, excluding thrombosis, excluding bleeding, they were all negative, and she had 5 infusions of IV iron and a Mirena placement, and even though she remained with an iron deficiency anemia. In terms of past medical history, just relevant for a stroke in 2017, where she was positive for factor V of Leiden, and she had some autoimmunity markers that were positive too. In terms of vitals, the patient was febrile. She had tachycardia, her blood pressure was on the lower end, hypoxemic on room air, and physical examination, she had a high GVP and a systolic murmur on the lower sternal border. And we could also notice cool extremities, but otherwise it was normal. So here we start to have two buckets. We have and I'm going to start unwrapping the case as long as we get some more information. So we have shortness of breath and iron deficiency. In terms of iron deficiency, we can have decreased intake, decreased absorption, or the cause can be blood loss. And in terms of shortness of breath, we can have all these causes: cardiovascular, pulmonary, chest wall neuromuscular, anemia. If it was chest pain, we have the famous 4+2+2. In terms of shortness of breath, we can also make this approach. And we start immediately to trying to connect, is the iron deficiency anemia causing the shortness of breath? We must remember that it was on exertion, so it might be indeed associated. But when we did the physical exam, the patient indeed had signs of right-sided heart failure. And in terms of blood loss, we can probably exclude as a cause given the negative studies. Therefore, we can probably start to understand that shortness of breath may have a cardiovascular cause, and the iron deficiency anemia could also be caused by decreased intake or decreased absorption. So moving forward, when we do a further clinical exam, we notice that the patient has purpura on the lower extremities, non-palpable purpura, as you can see on this image. And also, we can also notice that there is an asymmetry between the knees, and we can probably understand that this is a hemarthrosis. So we have a patient that is bleeding into the skin, purpura, and is bleeding into the joint. All right, so here we have to add another bucket, purpura. And this completely changes the approach to our case. It becomes indeed the center of gravity of it. So like we did for the shortness of breath and iron deficiency, let's look at the sign as it's considerably more specific. So we have palpable due to thrombosis. There is an inflammation in the vessel wall, and proximally, this thrombosis will increase pressure, and that's why the vessels are leaky, and that's why the blood goes to the skin. And we can also have an unpalpable, to which we associate bleeding. And this bleeding can have also many causes. So the thrombosis is most likely associated with vasculitis and inflammation of the vessel wall that predisposes to thrombosis. In terms of bleeding, we can have these three buckets: a vessel wall disease that can be hemorrhagic hereditary telangiectasia, which can be also amyloidosis, Ehlers-Danlos, scurvy, and then we also have coagulation abnormalities and platelet abnormalities. And we must understand that the platelet abnormalities can be quantitative or qualitative. So here we most likely have bleeding because the patient also has hemarthrosis. So let's think about bleeding. Bleeding can also be mucocutaneous or deep or visceral. So mucocutaneous bleeding is the purpura, but here we have a patient with also deep bleeding into a deep tissue in the joint. So there are not many causes, as we will see, that cause these two types of bleeding. Okay, so let's move on to the labs. So you have a patient that is a little bit leukopenic. He has the anemia that is still iron deficient. Um, Other studies are quite unremarkable. We have a low BUN, coagulation is normal, NT-proBNP is elevated, some markers of inflammation. Hepatitis and HIV are negative, as also the autoimmunity markers are also negative. And we also have a decreased folate. Then we move on to the imaging. Okay, we have a right axis deviation. CTPA shows no pulmonary embolism, and the TTE starts to show a compromise of the function of the right ventricle, which confirms at least by now the physical examination findings. So the doctors decided to pursue right heart catheterization and a VQ scan. This VQ scan was negative for CTEPH, which is chronic thromboembolic pulmonary hypertension. And these findings are consistent with pulmonary arterial hypertension. But let's stop a bit here and let's dive a little bit more into pulmonary hypertension. So how do we diagnose pulmonary hypertension? We diagnose pulmonary hypertension when the mean pulmonary artery pressure is over 20. Here, our patient has 41. So we can say that there are two types of pulmonary hypertension, which can be precapillary and postcapillary. So we need to look at some other variables. The PCWP, which is the wedge pressure, is rather low. It's under 15. So what can we say? The PCWP is a marker of the left atrium pressure and the end diastolic pressure on the left ventricle. So this means that if it was increased, the heart is not pumping blood as effectively, and therefore we have a PCWP over 15, and we call this postcapillary, as you can see here on the right. But we don't have it. It's under 15, and the pulmonary vascular resistance is increased. So this is a precapillary, but there are many causes of precapillary pulmonary hypertension, and we can have ways of approaching pulmonary hypertension. We have these 5 buckets, which I'll put here, and I'm not going to be exhaustive, but then you can take a look closer. This is a nice mnemonic to memorize all the 5 types of pulmonary hypertension, but all can cause precapillary except the number 2, which is related to heart disease. And here, when you are sitting on a chair, there's stasis. A chair looks like a 4. Stasis causes pulmonary thromboembolism, and then you have CTEPH, which we excluded. But the patient does not seem to have any chronic pulmonary disease. So after excluding CTEPH, we start leaning more towards the type 1 cause, which is pulmonary arterial hypertension, which has a lot of different causes, which we'll try to understand. In the ICU, the patient had pulmonary vasodilators and inotropes that led to considerable improvement, which is good news. And when we start looking at the shortness of breath deeper, we see that this heart failure was caused by pulmonary arterial hypertension, as confirmed by the imaging findings. And these can be inflammatory and non-inflammatory. So let's take a look at this amazing graph that is on the CP Solvers website. And we have inflammatory and non-inflammatory. In terms of inflammation, we excluded with negative autoimmunity, negative HIV. We also have a very common type of class 1 pulmonary arterial hypertension, which is genetic and idiopathic, which can make around 50% of cases. And nowadays, with the GWAS and genetic studies, we start to see that the idiopathic has been more reclassified as genetic, and that's the most common. And then we have the non-inflammatory causes. Okay, the patient does not seem to be taking any of these toxins, neither this medication. In terms of the metabolic causes, the liver panel was also normal. We start to think that probably we have some rare disease entity going on here. So this is what we have left. Looking back into the labs, we see that the patient has a low folate and a low BUN, and we had those dermatological findings, which start to make us suspect of a certain disease that is actually associated with both decreased absorption and decreased intake. If we look at the coagulation studies, they were kind of unremarkable, right? They were normal. So how can we have a purpura with normal platelets and normal coagulation studies? That's where we have this table. We have disorders of vascular integrity. We have disorders of fibrinolysis, the bleeding type, because disorders of fibrinolysis can also cause thrombosis. We have factor 13 deficiency, which is the only factor deficiency that actually is associated with normal PT and normal PTT. And we also have von Willebrand disease, and also other qualitative defects in platelets where we have uremia as a great example. But the first 3 probably don't explain the pulmonary arterial hypertension, neither the iron deficiency anemia. Oh, we have some participation here. Okay, let's keep on going. So this is what we have left. So what could be the diagnosis that joins all these dots? So the doctors called dermatology, and they were find a very, very, very specific finding: perifollicular hemorrhages and coiled hairs. You can see this on this image. So the final diagnosis, which we'll understand now, is scurvy. Interesting. Okay, so scurvy is a vitamin C deficiency, and it is associated with all the systemic findings: gingival hemorrhages, mood disturbances and cognitive impairment, petechia purpura, poor wound healing, these perifollicular hemorrhages and coiled hairs, anemia, And also a pronounced clinical presentation as myalgias and weakness and cramping that our patient actually did not have. So what is vitamin C and why do we need it? Vitamin C or ascorbic acid is involved in all these six homeostatic mechanisms. But our patient presented with disease that was affecting three of these. So collagen synthesis, and here vitamin C is involved in the formation of the triple helix of procollagen that forms the structure of the vessels. And we can also start thinking about vitamin C, and I also want you to remember it as a donator of electrons. And by being a donator of electrons, it helps all of these processes. But the most easy one to understand is actually iron absorption. So vitamin C donates one iron, and we get Fe2 plus, which is easily absorbed. And actually, the patient was presenting with the refractory iron deficient anemia because she wasn't being able to absorb. She was not being able to absorb, but she also had decreased intake actually of vitamin C. And lastly, why do we have pulmonary hypertension? Very recently, it has been recognized that vitamin C increases the nitric oxide synthetase activity. And as you know, nitric oxide is what increases GMP and leads to vasodilation of the vessels. And those vasodilators that I said before that the team gave and the patient improved actually inhibit the phosphodiesterase 5, which decreases GMP. So basically, they have a similar effect to vitamin C by increasing GMP and leading to dilation of the pulmonary vessels. Okay, so lastly, I just wanted to tell you this very important teaching point. In nutritional deficiency, we usually have anemia. And when it is associated with leukopenia, we have to think about the two C's. And when we have thrombocytopenia, we can also think probably lean more towards folate deficiency and B12 deficiency. Okay, so how can we not have scurvy? That's a great question. So prevent scurvy, here 10 milligrams, optimal health 200 milligrams. But what is also interesting about this case is that when we see a patient with nutritional deficiency, we need to think not only on diagnosing and treating. There's much more, a systemic issue, a social issue. In fact, we have to think about socioeconomic factors, mental illness, substance abuse. And when we want to make a sort of intervention, we need to think about the community and we need to think about public health. Actually, this was not the case of our patient. Our patient was allergic to citrus, so she was not eating oranges or lemons. And what is interesting is that this disease, scurvy and vitamin C, has been described by ages from the greatest empires before Christ. They still were already describing this disease. And actually, when we are growing up and we are learning how the sailors went to the sea to discover the world, we, since very young, I've always heard about scurvy. So if you go to a Portuguese boy or girl that is learning history, you probably know what scurvy is because we were terrified of our gums starting to bleed. So we got home and we asked our moms to give us oranges. So I remember that very vividly. And if you want to achieve this optimal health, actually oranges and lemons are more than enough. But if the highest concentration of vitamin C is actually the chili pepper. But please don't tell your patients to start eating chili peppers because they can have other types of adverse effects. And actually, we must also remember that vitamin C excess can also lead to nephrolithiasis by causing oxalate stones. So lastly, why is this case so special? So Mark said it was one of his favorite residency cases, around the top two. Then it's a very rare manifestation of a vitamin deficiency. For me, it's actually amazing how a vitamin deficiency can cause pulmonary hypertension. It's amazing. It's a disease I've heard since I'm very young, so it's actually fun to talk about it. And it's a case full of learning. And what did we learn? We learned about the different types of purpura. We learned about bleeding disorders with normal platelets and coagulation. We learned about pulmonary hypertension, causes and mechanisms. And we also learned how vitamin C is vital to a diverse array of homeostatic processes. So I'll finish as I started. When life gives you melons, make sure you eat them unless you are allergic to them. Okay, thank you so much.
Thank you so much, Francisco. That was amazing. Love also the historic pearls. Love how well that case was incredible, and love how a nutritional deficiency can have so many different manifestations. I didn't know at all about scurvy causing pulmonary hypertension, but by decrease of nitric oxide. So thank you so much for the great explanation. And we'll pass the mic to Tansu, that has also an amazing case.
Well, thank you so much, David. And thank you everyone for being here. Francisco, I don't know if I love your presentation or your sense of humor more. It was amazing. And now I will share my screen. Please let me know if you can see it. Do you see my slides?
Yes.
Perfect. So in this teaching point recap, I will talk about the case that Shreyas presented to Alec and Rabi on 29th of February, and the case was Langerhans cell histiocytosis. So let's revisit our problem representation for those of us who haven't been able to attend to that VMR. So we had a 50-year-old female patient with a past medical history of hypertension and diabetes mellitus, and she had a 4-month history of polyuria and polydipsia, 3-month history of worsening shortness of breath and abdominal distension, and recent black tarry stools. On the physical exam, our patient had icteric sclera, palpable anterior cervical lymphadenopathy, massive hepatosplenomegaly that was later confirmed with ultrasound, bilateral crackles at the lung basis, and extensive petechial rash on the abdomen and back. And in the labs, our patient had hypernatremia, elevated ferritin in 3000s, low albumin, and panhypopituitarism. And in the imaging of our lumbar spine in the MRI, we saw that there were lytic lesions with sclerotic margins, and the brain MRI showed absent pituitary bright spot, no stalk enhancement. Despite the medical interventions, unfortunately, our patient, Shreyas' patient, succumbed to her condition. And in the post-mortem biopsy of the pituitary gland, it confirmed the diagnosis of Langerhans cell histiocytosis. And here's a timeline of our patient's clinical symptoms. So a conversation about histiocytic neoplasms, I think it requires a little bit of talking about the hematopoiesis a little bit. And here we are specifically interested in this pathway right here. And we are interested in the monoblasts, which give rise to monocytes, which stay in the bloodstream for 1 to 3 days. And then depending on the interleukins being secreted by the tissue fibroblasts and other cells, monocytes either evolve into macrophages or alternatively dendritic cells. And here we have clonal proliferation of one of these cell lines, either macrophages or dendritic cells, but they're both monocytic in origin, and that's basically what how Langerhans cell histiocytosis developed. And when we visit the definition of histiocytes, what are histiocytes? Histiocyte quite literally translates tissue cells, which are designated to refer to mononuclear phagocytes, which are, as we spoke in the previous slides, macrophages, and dendritic cells. And the histiocytic disorders is an umbrella term. It's a unifying concept for many disease etiologies. And these can be malignant or benign or neoproliferative. And the common pathogenesis is that there are pathogenic myeloid cells that resemble macrophages or dendritic cells in the case of Langerhans cell histiocytosis. So classically, in the past, the classification of histiocytic disorders based on the terminal phenotype of the cell. And Langerhans cell histiocytosis was named so because they carried an antigen, CD207 antigen, that are also seen in the epidermal Langerhans cells. But the updated classification now takes into account the molecular changes and the clinical features. So let's talk about infiltrative diseases before going further into the specific infiltrative disease category that we will talk about, and especially Langerhans cell histiocytosis. What are infiltrative diseases? So those are, that's also an umbrella term for many etiologies where a cell or molecule or an infection accumulates in one organ or many organs. And the diagnosis is a little difficult because they can involve many organ systems. And how can we diagnose infiltrative disorders? First, we can look at the visible, whatever we can see in the physical exam, the visible clues, or we can get some help from the labs that give us an information about the function, the decreased function of the infiltrated organ. And I just want to give a shout out to Andrew for letting me use this schema, infiltrative disease schema. Thank you so much, Andrew. And we are going to be right here today in the histiocytosis, and especially the Langerhans cell histiocytosis. So let's look at the classification of histiocytic disorders. The current classification is divided into 5 groups. So in the first group, the C group, these are cutaneous non-Langerhans cell histiocytic disorders. I'm not going to go into detail for each of it because I want to spend more time in my later slides, so I'll just give an overview here for you. And the H group involves the HLH. So HLH can be primary because of a cell line mutation, or secondary in response to a malignancy, for example, an inflammatory process in the body. And then the L group includes both Langerhans cell histiocytosis, indeterminate cell histiocytosis, and Erdheim-Chester disease. And Erdheim-Chester and Langerhans cell histiocytosis can coexist together, and that's called mixed LCH-ECD phenotype. And then in the M group, we have the primary malignant histiocytosis and secondary malignant histiocytosis. So that's the malignant group. And in the R group, we have the Rosai-Dorfman disease. And as you will recall, if you attended that VMR on January 19, we had a case of Rosai-Dorfman disease, which was very interesting. It was the first time that I got to know this etiology. And so I just put together this spectrum just to make our understanding easier and just to simplify the information that you saw about with the classification. On this end of the spectrum, we have hyperproliferative disorders. So these are our malignant histiocytic conditions. And here we have Langerhans cell sarcoma and malignant histiocytosis. And on this end of the spectrum, we have HLH, and that's the immune dysregulation category. And in the middle, right in the middle, we have Langerhans cell histiocytosis, Erdheim-Chester, and Rosai-Dorfman disease. And those are both inflammatory and myeloproliferative neoplasms. So the terminology that's now commonly used for this disease category is inflammatory myeloproliferative neoplasms. And as you will recall from my problem representation, the ferritin of the patient was in 3000s, which is quite high. So that just speaks to the inflammatory nature of the disease. So what are the key features of Langerhans cell histiocytosis? Why does it happen, first of all? So there's a clonal proliferation, and the most well-identified mutation is the BRAF V600E mutation, which is a gene that plays a role in the MAPK pathway. And that pathway regulates so many cellular processes, proliferation, apoptosis. So that's a really, really key pathway. And then when the cells have this mutation, they start to proliferate excessively, but not in the range of hyperproliferation, not in the range of the malignant category, let's say. And so this activates an exuberant inflammation, and the inflammatory infiltrate includes many cell types: neutrophils, sometimes eosinophils, plasma cells, all sorts of inflammatory infiltrate, not just the monocyte origin cells, not just the dendritic cells and macrophages. And so usually, who is the demographic that's affected by Langerhans cell histiocytosis? Primarily children, but there's also a second peak in the third and fifth decades of life, between the third and fifth decades of life. And it affects the men and women equally. And the clinical manifestations of the disease, we will see it in the next slide. But let's just talk about how we diagnose Langerhans cell histiocytosis. So the 18F FDG PET-CT is really useful to find the metabolically active focus, so the infiltrated tissue in the body. And the MRI is especially good for the vertebral lesions. And biopsy confirms the diagnosis, and biopsy is usually guided by the PET-CT. And the treatment of Langerhans cell histiocytosis is beyond the scope of this presentation, because this is also really complicated and it requires experts to speak to. But I will just say that if it's a low-risk disease, if there's a single foci, then we wait and watch, and we curatize or excise that tissue specifically. But if there are bone lesions and in high-risk anatomical regions, and the most common location for these bony lesions is the skull in Langerhans cell histiocytosis, or there's multifocal involvement or systemic manifestations, then we use chemotherapy and treatments such as vinblastine and prednisone. And then when we come to the clinical features of histiocytic neoplasms, we'll just look at the three diseases here: Erdheim-Chester, LCH, and Rosai-Dorfman. Why? Because these are the diseases, histiocytic neoplasms, that affect adults mostly. There's another one, JXG, juvenile centrogranulomatosis, that mostly impacts children, so we're not going to talk about that. So I created this heat map to understand the organ involvement of these histiocytic neoplasms better. And the first thing that probably will catch your attention is Erdheim-Chester is so diffuse in its involvement that it involves the bones, and when the bone involvement, it's present in 95% of the cases, and when it involves the bones, it's usually bilateral, sclerotic, and around the knees, and that's pathognomonic for Erdheim-Chester disease. And differently than the other two histiocytic neoplasms, Erdheim-Chester also affects the heart and the arteries, specifically aorta and renal artery, and that's very unique to Erdheim-Chester. And it also has an impact on the pituitary gland, and commonly presents with diabetes insipidus, which can precede the presentation of other symptoms by years sometimes, which is also the case in Langerhans cell histiocytosis. And in Langerhans cell histiocytosis, we have bone involvement, we have respiratory involvement, which is the most common in LCH compared to the other two histiocytic neoplasms. And in 90% of the cases, smoking was found to be associated with the pulmonary Langerhans cell histiocytosis. And it causes characteristically eosinophilic granulomas in the lungs. And when we look at Rosai-Dorfman disease, we see that compared to Erdheim-Chester and Langerhans cell histiocytosis, it's not that diffuse. It involves primarily the skin and the lymph nodes. And as you remember from the January 19th case, our patient in that case had a massive cervical lymphadenopathy, which is a very characteristic lymph node that Rosai-Dorfman disease involves. And so we talked about both Erdheim-Chester and Langerhans cell histiocytosis impacting the pituitary gland and causing diabetes insipidus. So I just looked at what are the causes of pituitary gland involvement, in what kind of diseases is the pituitary gland involved. And so there are primary pituitary gland diseases, but there are also secondary causes of hypophysitis, the inflammation of the pituitary gland. And in that category, we have numerous causes. It can be either drug-induced, and this happens secondary to immune checkpoint inhibitors or monoclonal antibodies, like you can see here, or some autoimmune diseases. And in that category, we have the Langerhans cell histiocytosis and Erdheim-Chester disease and sarcoidosis. And in the malignancy category, we have a lot of malignancies that exist in specifically in the cranium that also infiltrate the pituitary gland. And the pituitary gland can also be involved as a result of a paraneoplastic process or metastases, commonly from lung, breast, prostate, and kidney disease, and infections such as TB and syphilis. So what are some take-home points that I want you to take from this presentation? When the center of gravity is not very apparent, when the symptoms are so disseminated, and Alec captured the essence of this situation so well by saying, I did not know how things could be more positive when Shreyas was presenting his case. So what should we do? We should look at patient's chief complaint first, because what patient is bringing to our attention sometimes, in most times, demands the most attention from us. So we can either focus on patient's chief complaint, or we can assess the severity and acuity of symptoms by our physical exam and the labs, and then integrating the patient's history, the history they are giving us, and our own observations with the patient's chart. And we can also choose the symptom that has the narrowest differential diagnosis. And in this case, the symptom that the patient presented to the hospital first was polyuria and polydipsia. And that's also the symptom that has the narrowest differential diagnosis. So focusing on these three factors really help us to help us find the center of gravity in the patient's case. And then in the infiltrative diseases, we have to weigh in the relative invasion of different organs. And to be able to do that, we need to develop illness scripts for each infiltrative diseases. And we have to know what organs or systems they have the highest propensity for, which organ systems they affect most commonly. And we should also remember the pulmonary involvement in infiltrative diseases is common, and lungs are usually the source of infiltration. This is especially true in the case of infectious infiltrative diseases. But in this case, the lungs were not the source of infiltration because the patient first came with polyuria and polydipsia and then developed the shortness of breath, the lung symptoms. So this is just something to keep in mind when we are also assessing the center of gravity of the disease process. I just want to talk about my references a little bit. I got the hematopoiesis flow chart from the Wikimedia Commons. And I got the epidemiologic information management treatment part about the Langerhans cell histiocytosis from this article, the second article right here, which is an article from the Nature Review of Diseases primers. And these articles are specifically targeted towards early stage trainees, medical students, just to understand complicated disease processes more easily. And then the third reference that I used was the Mayo Clinic Histiocytosis Working Group consensus statement. You can check this article out for more information about the specific organ involvement of Erdheim-Chester, Langerhans cell histiocytosis, and Rosai-Dorfman disease. And then the last article, I used that article to summarize the pituitary involvement in different disease processes. So you can also take a look at that if you're interested in learning more about it. That's all from me. Thank you so much for being here and for listening to me. I hope you have a wonderful day. And I will pass the mic to Jimena.
Thank you so much, Tansu. That was amazing. A very difficult topic that you summarized and did an amazing approach. I think. Well, you can read the chat to see the comments because it's incredible the work you've done. I'll pass rapidly the mic to Ximena to tell us her case, and yeah.
Well, thank you so much, David. I want to say that I want to give a shout out to both Francisco and Tansu. They have both made like really, really amazing presentations worth watching again when this record is up in YouTube. Thank you so much for giving me the opportunity to also do a teaching points recap. This is my first time, so please bear with me. I'm going to start sharing my screen. I don't know if you guys can see it. Okay. Sounds good. So for this presentation and these teaching points to recap, I decided to choose the case that was on February 28th. This case was discussed by Jack and Charmaine, and it was presented by Avir, which she is another Academy CP Solvers member, and she did a great job presenting this case to us. She started telling us about a 34-year-old male patient that presented with bilateral calf pain that had lasted for the past 4 days. And we also knew from the HPI that this patient has had an episode of strep throat that was treated with amoxicillin clavulanate, and this episode was 2 weeks ago. However, the patient developed this bilateral calf pain, which was examined, and at that time it didn't show any neurological pathology. And the patient reported that the fever had resolved with the treatment. However,
one moment, please. Can you try to reshare your screen because we see it like charging, but
oh, sure. Can you guys see it now?
Yeah, perfect.
Okay, thank you.
Great.
So just doing like a small recap before this technical issue. We knew that this patient had received the antibiotic therapy and his symptoms had resolved. However, this muscle pain in both calves was not resolved, and it was causing him difficulty to walk and climbing stairs, especially. So when we think about calf pain, it's easier to just make this into buckets and try to think about what could be causing this pain. And Jack and Charmaine did this amazing approach when we have to think about vasculature. Is it a problem with the arteries, the veins, or both? Is this patient having an artery insufficiency? Is this patient having a thrombi? Are we dealing with a pathology that can affect both of them, like antiphospholipid syndrome? There we can also think about the muscle per se, that can be dealing with inflammation and specifically a myositis, or we can also be dealing with the myopathies, which is a big, big realm. And then problems in the skin. Are we having an infection? Is there something else in the skin, like a rash, that can be causing this pain? And then we also had a pretty big bonus of things to consider in this case, because we knew that this patient had a past medical history of a streptococcal infection. So it's early on in the case, but do we have to start thinking about if we're dealing with complication of a streptococcal infection? And we know that can be really broad, that can go from rheumatic fever to other like really uncommon pathologies like sweet syndrome. So even though it's early on the case, we have that history, and it's important to just consider and have it in our minds. And as we knew more about the HPI, Abir shared with us that a provisional diagnosis of a post-viral or maybe a drug-induced myositis was done, and that's why the patient was discharged with analgesics. However, the pain worsened, and while the patient was taking, anti-inflammatory and anti-pain medication, it really did not improve. So that's just like a red flag for us of saying, like, what is going on and why, despite treatment, this patient is actually not getting better. In the past medical history, we have that this is a healthy patient. That's why the only medication that he was taking was the antibiotic for the strep infection. We also know that he is a smoker, which could also play a role into thinking about the vasculature, if that's one of the hypotheses that we're dealing with. With the vitals in the physical exam, the vitals were stable, and the only thing positive in the physical exam was that we found bilateral swelling and tenderness over the gastrocnemius area, which is basically very consistent with what the patient had been complaining about. And in the initial labs, we see that we had just a slightly elevated white blood cell count with a neutrophilic predominance. We do see that we have thrombocytosis. We have a CRP that's slightly high, which is an inflammation marker. And then we also have a little bit of elevation in the AST and ALT, which at this point could also be related to the fact that we're dealing with muscle. We have to remember that these enzymes are not only in the liver, they are also in the muscle. And if they are slightly elevated and we're having a little bit of muscle rupture, they can leak into the blood system and just be slightly elevated when we take a blood sample. So with all the information that we have right now, we're getting into the inflammation realm. Why? Because first, the patient is reporting pain. We also have a thrombocytosis in the labs, and it is kind of difficult to differentiate at that point in time if we're having a reactive thrombocytosis or it's an active process. However, if we are able to trend the platelets, that's going to be helpful for us to differentiate between these two. We also have other inflammation markers that were slightly elevated, like the CRP. And with the clinical picture that we have in the HPI, we could possibly be dealing right now with a syndrome, because we have an upper respiratory tract infection that was treated with antibiotics, and now we're having a constitutional symptom, which was the muscle pain. So we also need to consider in our differentials some other viral infections like EBV or other mono-like viruses that may be playing a role into what we're investigating in the patient right now. But we also would like to see other symptoms like, are we having a rash, or are we having some hemolytic anemia? Those would be clues that could help us differentiate from a possible syndrome. And now that we're in the inflammation realm, we need to start thinking about inflammation causes. And this is, I want to say simple, but it's actually not simple, because we have the three usual buckets that are inflammation, cancer, and immunological causes. For this case in particular, we're thinking about more subacute infections. Because this patient is young, cancer right now it's important, sorry, to consider, but it's not going to be the main focus with what we have right now. And then we also need to consider some immunological diseases that would also go with the age of the patient. We could be dealing with a vasculitis. We know how diverse vasculitis can present. And we also need to start thinking about some immune-mediated complications. If we're thinking about an infection, and especially infections like strep, we can have that as an immunological trigger. So we just have to balance here and try to define which is the problem that we're dealing with. We also figure out other labs. We found out that the IgG was low. From the infections panel, we saw that we had an IgG that had a high titer for EBV, which at this point, it's not that alarming because we're only dealing with IgG. You know, we don't have a positive PCR, and then the IgM is borderline. So that just like reduces the possibility of this patient actually be dealing with an EBV infection. And of course, our autoimmune panel. In this autoimmune panel, we were trying to think about vasculitis, and we were evaluating myositis with all the antibodies that the patient got. And all of the information that we had so far didn't reveal that much until we got to the imaging. When we did imaging to the patient, we saw that we had nodules that were diffuse. We had nodules that were pulmonary. We had nodules in the armpit. We also had more nodules in the abdomen that were retroperitoneal. We also had another nodule that was inguinal. And of course, because of the main complaint of the patient, they decided to get an MRI. And now the MRI revealed that we were possibly dealing with myositis. So just to do like a small recap of where we are so far, we have a 30-year-old male patient with past medical history of a strep throat infections that was treated with amoxiclav, and he was consulting for muscle pain. In the evaluation, he was found to have diffuse lymphadenopathy and a possible myositis. So now we're thinking about dealing with a systemic inflammatory process. And what are going to be our differential diagnosis so far? The buckets are still going to be the same, and that's why I said at the beginning that it's easy to mention the buckets, but it's actually not that easy to identify what we're dealing with. If we're thinking about infections, we would consider granulomatous infections that can be very insidious and subacute. If we're thinking about cancer, we can include into our differentials a lymphoma, a myeloproliferative disorder, and some other autoimmune diseases that are associated to cancer. And of course, we're still thinking in the immunological bucket about vasculitis, specifically GPA. And because now we have an image that is suggestive of myositis, we're getting into that realm right now of thinking about, is this a polymyositis, a dermatomyositis, like any other idiopathic inflammatory myositis. And Avir also shared with us another amazing differential diagnosis that was the Kikuchi-Fujimoto disease. This is a very, very weird disease. And if we're thinking about it, this patient actually has a lot of symptoms that can be associated with this disease. The lymphadenopathy, in Kikuchi-Fujimoto disease, it tends to be cervical posterior. We didn't have that specifically in the patient, but he did have regional lymphadenopathy. We can also find mild fever. Patients can also have upper respiratory symptoms because it is believed that this disease is related to the presence of a virus. And in a lot of cases, actually half of them, we can find leukopenia. So far, what's next? Like, what other things can we do that are going to actually guide us and make progress to finding out what's going on with the patient? So, you know, they say tissue is the issue, and that's why right now we're going to get a biopsy. And in this case, they did a CT-guided biopsy that revealed some polygonal cells that were arranged in small nests. While they're doing the CT guided biopsy, they figure out that there was more lymphadenopathy that was adjacent to the kidney. And with the sample that they had, they do some immunohistochemistry, which was positive for synaptophysin, chromogranin, and GATA. And this is pointing to neuroendocrine tumors, which actually turned out to be the diagnosis in this case. It was a paraganglioma. And when we talk about paragangliomas, we actually have to talk about pheochromocytomas too. I like to think about them as brothers because both of them are neuroendocrine tumors that are going to arise from the chromaffin cells. The only difference between them is the location. Pheochromocytoma, we know that it's going to be specifically in the adrenal medulla. However, a paraganglioma can appear anywhere in the body. And it's because it's going to arise from the autonomic nervous system ganglia. So anywhere that we have them, we can have the occurrence of this tumor. And we're going to see that they are actually really rare. If you see the annual incidence in the US, it's really, really low. And they tend to peak in the 3rd to the 5th decade of life. And when we talk about these tumors, it's important to classify them. Why? Because they can be very insidious. So we can have the classification according to the symptoms, either they present with symptoms or not. We can also have the classification if they are producing catecholamines and we're actually able to measure them in blood, and we're going to call that secretory or non-secretory. And then there's also another path classification that it's going to be if the tumor has catecholamines in the tissue, which is going to be functional or non-functional. And why is this actually so important? It's because it's going to be dependent on the catecholamine production that we're going to find these tumors as we expect them to be found. So if we have a tumor that is producing catecholamines, then we're going to have those symptoms. We're going to have headache, palpitations, sweating, hypertension, also other vasoconstriction signs, and even anxiety. However, if these tumors are not producing the catecholamines, we're going to have really non-specific symptoms. And most of these patients are either going to present as having symptoms of a mass effect, like either pain or neurological deficits because of compression. And in some cases, we're actually going to be able to palpate the tumor. But if that is not the case, they're going to be classified as incidentalomas. And you're going to see that it is actually very common for them not to produce catecholamines. This diagnosis is actually a combination of a lot of things that you can do. Why? It's because the presentation is so broad. So if we have a patient who has symptoms, then we can take into account the clinical picture, do the imaging, and then try to measure those catecholamines in blood or urine. However, if the patient is not presenting with any symptoms, the most common case, it's going to be that we're going to find this tumor through imaging, and then we're going to have to do all the process kind of backwards and trying to figure out the origin and the nature of that tumor. But just for you to know that you have all of these tests that you can do to help you guide the diagnosis, but it's going to be mostly, there's no order. It's going to be dependent on the presentation of the patient. And I found this really, really great systematic review about the presentation of both tumors. They condensed 85 articles and they were able to get 157 cases. And I know that 157 does not sound like a lot, but when you think about the incidence and the prevalence of these tumors, it is actually a significant sample. And I just want to highlight some things about this table. First is the age of the diagnosis. We can think about the 45 plus minus 15 years, which fits with the age that this patient presented. Also, another thing that I want to highlight is that this tumors, actually a little bit more than half are going to be extraadrenal, and we tend to think that pheochromocytoma is like more common, but according to this, the presentation, it's actually more common to find a paraganglioma. And as you see, more than half of them are going to be incidental. So that's just going to change a lot our approach. And it was actually the case of this patient, because this patient didn't have any catecholamine secretion symptoms. And you're going to see that there's a really, really low percentage of patients that are going to have specific signs and symptoms, which should raise our alarms to include this in our differentials. And you know, we learned in medical school about measuring metanephrines in blood and urine. It's a classical board question. But the truth is that because a lot of these tumors are not actually secreting the catecholamines, finding these tests are not going to always exclude the possibility of we having a diagnosis like this. And lastly, something that was very interesting for me about the case was how could we reconcile the fact that we had myositis and a malignancy? And I want to highlight that this was just not the case in this patient, because with the information that we were given, we cannot do this assumption and this association. But it was a nice teaching point for myself, and is that we can have cancer-associated myositis. It's a really, really topic. It's a broad topic that we can dive into another day. But in the article that I found, this was defined as patients developing cancer and an inflammatory myopathy within a 3-year period. The myopathies that were most associated with this were the dermatomyositis and necrotizing myopathy. This is a topic, a little bit of discussion with the antibodies, but there's a promising information with the P155/140 antibodies, because they are specific to dermatomyositis, and they can they found out that patients that had this positive antibodies were more prone to actually develop cancer. So this is a topic that I invite you all to go and research more on their own. Thank you for bearing with me for this whole presentation. I hope that you all liked it.
Thank you very much, Ximena. That was also an amazing breakout of that case that was also very, very difficult. You all of you picked some very difficult cases, I think, and that have very a systemic print that was difficult to discover in the presentations. But love how you recover all the key features of the case. We are a bit ahead of time, so we're finishing this session, and thank you everyone for being here, and see you tomorrow. Bye.